your computer in front of you, you'll probably be fine, but if you'd like a hard copy, they're right over there on the desk and Sarah can help you out. We'll give folks just another, thank you, Ted. We'll give folks just another minute here to get situated. If you are joining us on the Zoom as a MAC member, would you please put into the chat your name and the organization you represent so that we have that for our meeting minutes? Okay, Terry, do you want to kick us off?
Sure. All right. Thank you, everyone, for joining us today. Put it closer. I have kind of a big mouth, so. Anyway, so I will call this meeting to order and ask for a first and second proposal to approve the minutes for the last meeting.
I approve.
Or I guess I'm.
Or I make a motion.
Motion, thank you. We have a second.
Second?
My second.
You can second.
Second. All right. I won't necessarily ask for approval if anyone has any issues or would like to discuss anything. Say so. If not, we will consider them approved and I will turn it over to Cora.
Okay, great. And maybe we can do quick introductions. I can, if you haven't included your name and organization that you represent in the meeting chat on the Zoom, please do so. We can just read through those, but otherwise we can just sort of go around the room. If you're a presenter and not a MAC member, just indicate so as we go around. So Terry, if you want to start.
Sure. So I'm Terry Cole. I am also the co-chair of the committee and I am with the Indiana Hospital Association.
I'm Herb Hunter. I'm a MAC member and I represent the Indiana Pharmacists Association.
My name is Lynn Mong, and I am the Director of Hip and Hoosier Healthwise for Office of Medicaid Policy and Planning, and I am presenting today.
Hi, I'm Nana Spinner, and I am the Director of Eligibility for the Office of Medicaid Policy and Planning and presenting today.
Good afternoon, Michelle Holkamp, Communications Director for FSSA, and I am a presenter today.
Light isn't working on this, but I think the mic's working, isn't it? Yeah, there's just no light. Ed Clear, State Representative from New Albany.
Good afternoon, Amy Kent, Deputy Health Commissioner and current Interim Chief of Staff at the Indiana Department of Health.
Blair Hadley with the Insurance Institute of Indiana.
Amanda DeRoss, Staff Attorney with FSSA.
Kathleen Dellinger, Director of Quality Improvement, LMPP, and I will be presenting today.
Giovanni Bonilla, Director of Political Operations, and I will be presenting today.
Cora Steinmetz, Medicaid Director.
Holly Cunningham Piggott. I am the Director of Care Programs for the Office of Medicaid Policy and Planning, and I am presenting.
Kimberly Bremer, I am the Director of Pathways at HCC, and I am presenting.
Good afternoon, Fadi Kadura, representing Senate District 30, north side of Indianapolis.
And online we have Rodney King with the Licensed Practical Nurses Association, Luke McNamee with ISMA, Dr. Sarah Boslett with Indiana AAP, Danielle Coulter with the Indiana Speech Language Hearing Association, Representative Mike Karakoff, Elizabeth Eichhorn with IHCA, Representative Robin Shackelford, Senator Ed Charbonneau, Shane Springer with the Indiana Dental Association, Andy Zellers on behalf of Zoe France with the Indiana CMHC Council, Katie Stafford Cunningham with INAR, Representative Barrett has sent a legislative assistant on his behalf, Katie Feely, CEO of the Indiana State Nurses Association. All right, thank you very much. I believe we're ready to get started then in the substantive portion of our agenda. And first, I will turn it over to Amanda DeRoss for a rulemaking update.
Thank you. Hi, my name is Amanda DeRoss. I have two rules to present today. They are LSA 23819, the Article 2 rule, and LSA 2458 nursing facility rule. I presented both of these at the last meeting, so you've heard them before, but they are still in the promulgation process. So I'll just give a brief overview and where it's at now in the process. And then if you have questions about the process, I can answer those. If you have substantive questions, we have subject matter experts with OMPP. So the first one, again, that's Article 2 rule, which is LSA 23-819. And this proposed rule amends 405 IAC 2, which concerns updated definitions, guidance, and clarification of terms, and aligns IAC with federal code. So previously, a second public hearing was held for this rule on April 22nd, 2024. The Office of General Counsel and OMPP are reviewing public comments we received at that meeting, preparing agency response, and making amendments to the rule language in response to the public comments we received. After that, once the rule is approved and adopted by the Secretary, the final rule will be submitted to the Office of Attorney General and the Governor's Office for review and approval before being published with the Indiana Register. Next, I have the nursing facility rule, which is LSA 24-58. And this proposed rule amends, adds, and repeals rules at 405 IAC 1 concerning fee-for-service nursing facility reimbursement. A notice of second public comment period and hearing will be posted on May 29th for this one, and then a second public hearing will be held on July 1st. Are there any questions about any of the rules? If not, then that concludes my presentation. Thank you.
Thank you, Amanda. All right, Terry, okay, if we just keep proceeding through the agenda? Okay, fantastic. So just briefly, under Medicaid Director updates, the bulk of what we have to share for you, we have a number of representatives from OMPP and FSSA who will be providing most of our substantive updates. The only other item I wanted to add and share with you all is around the improvements to forecasting and budget monitoring that we have been continuing to work on. You'll recall this is an area that we spoke about in February following the December forecast. So we're very pleased to share that about 10 days ago, we shared our first monthly financial reporting report on the FSSA website. So we'll be sure to include a link to that in the meeting minutes that are sent out after this meeting. This is a very robust view of enrollment, expenditure, and funding information for the Medicaid program across all of our various programs and delivery systems, both fee-for-service and managed care. And shows information both on a variance basis from the Medicaid budget or our appropriation amount, as well as the most recent forecast, which in this case is December. So there's a lot of great information in there. There's a very helpful how to read guide that kind of explains the definitions of the various different rows and columns in these sheets because they are quite detailed. And then similarly to how state budget agency structures their monthly revenue reports, we also have an accompanying commentary and narrative that sort of speaks to drivers of any variances or what we're seeing along the lines of growth in the program or unexpected increases or decreases, both from an expenditure, enrollment, or funding standpoint. So encourage you to have a look at that information. If you have any questions, please feel free to reach out. But we're really excited about this. Sort of in parallel, we're continuing to move forward with our policy change review process, which is sort of the corresponding prospective look at programmatic policy changes to ensure that from a financial standpoint, an operational systems, programmatic standpoint, we have a clear understanding of policy changes, be it state plan amendments, changes to Indiana administrative code or other administrative level changes to waivers or other programs well in advance of them being implemented. So those will continue to keep you updated on those. Recent legislation also will have us provide information about this at the Medicaid Oversight Committee. And so we'll share those updates there as well, but just wanted to make sure that the MAC had an opportunity to hear about that. Any questions? If not, I think we can jump into our first presentation. So we are joined by Nana Spinner, our OMPP Director of Eligibility and Member Services, and Michelle Holtkamp, our FSSA Director of Communications and Media. Very excited to share some information as we've completed our Medicaid return to normal. Thank you, Cora. Can everyone hear me? I think you need to speak just a little louder. Okay.
So want to give just a summary of our activities as we have been unwinding, as it's been called, or returning to normal, as we've called it within Indiana. Our first post-public health emergency renewals for Medicaid were due in April of last year. We did have 12 months to finish our work with an additional 2 months to wrap things up, so for a total of 14 months. But our final PHE-related renewals were due in March of this year. Apologize, that's 2024. We'll get that corrected. We have processed renewals for over 1,785,104 members over the last 12 months. So it has been a giant effort on the part of especially our Division of Family Resources, and we appreciate all of their hard work helping us get through that. So each month, an average of 148,759 members were due for renewal. And of those, an average of 52% had their coverage successfully renewed. Of those who were renewed, 78% were auto-renewed. You sometimes hear that called ex parte renewal. That means that we had enough information in our system to see that they still qualified. The information was recent and reliable, and so we renewed them without the member having to take any action. Out of the total population of those due for renewal, our ex parte renewals were 41% of the total who were due for renewal. An average of 32,101 or 22% of the total that were due for renewal were disenrolled from Medicaid each month. Of that, 3% were determined ineligible based on information that they provided. Most of these would have qualified to have their account transferred to the federal marketplace or healthcare.gov so that they could apply for coverage there. And just a reminder that there is a special unwinding enrollment period that is still active. It's actually been extended through November 2024. So individuals who lose Medicaid for any reason can go to healthcare.gov and apply to see if they can get coverage there. And this extends that period until the regular open enrollment opens. So it does give them kind of a longer runway to find other coverage if they found that they are no longer eligible for Medicaid. 18% of the total that were due each month were disenrolled due to procedural reasons, such as a failure to respond to a request for more information. Of those who were disenrolled for procedural reasons, 7% were closed because they just did not respond and we did not have enough information on them to see if they were still eligible. 4% were suspected to be ineligible. For example, we knew based on the information we had that they were over the income limit. They did not supply any new information to show that that was wrong. And so that was 4% of the individuals that were included in the procedural terminations. And 2% provided incomplete information or were known to be eligible. For example, we knew that they were deceased or they no longer lived in Indiana. Of those who failed to respond, our records show that 21% have regained their eligibility by submitting their missing verifications during the 90-day reconsideration period. In Indiana, this has always applied to both our HIP and Hoosier Healthwise groups, which we call MAGI, and also our age-blind disability Medicaid coverage, which is non-MAGI. Not all states do that. We've always done that. This 90-day reconsideration period is a function of our renewal processes that will continue past the unwinding. And the reconsideration period is still active for those who were due in February or March. So they still have time to come back. If they miss their deadline for turning their paperwork in, they still have time to turn that in without having to file a new application. Of those who were disenrolled for procedural reasons, our data shows that an average of 35% were known to have other insurance coverage, such as commercial coverage or Medicare. So many of those who were disenrolled may have chosen not to return their form because they didn't need the Medicaid anymore. We did have some people who didn't know they had Medicaid during this time. And Indiana, along with Tennessee, adopted the highest number of 1902 E14A unwinding waivers among all states and territories. We adopted 15 of these waivers and flexibilities to increase successful renewals and decrease procedural terminations. And then we've got a chart here that kind of shows you the progress. And, you know, we've been in these MAC meetings and we've experienced this progress or lack thereof together as we've gone down this road. So you can see the blue line on top is those who remained enrolled. And we started out at a lower percentage. You can see in the, lower 40%. And then as we continued on, we learned, people heard that this is really a thing and our communications were effective. Our stakeholders helped get the message out. We've seen that the percent who remain enrolled has increased quite drastically. The green line is for those that were not completed as of the last day of the renewal month. And just as a reminder, these individuals still have coverage while we're processing their paperwork. And so that stayed fairly steady throughout the process, this 12-month process. And then you can see the gray line is the total number disenrolled. So again, we started out in April pretty high, higher than we wanted it to be. And then as we progress through, we've gotten it down to, in March, our final month, we were under 10%. Something that is new in the past few months is we're also now reporting to CMS on what happened to those pending individuals, the ones that we weren't done by the end of the month. Maybe they turned their paperwork in too late for us to pick it up in time for that last day of the month process. So 90 days later, we're reporting on that to CMS, and you can see that on our dashboard. I've got an example here of the most recent month we reported on, which was January. And you can see that at the end of January, we had 36,484 members who were still pending, meaning they kept their coverage. And 90 days later, 37% of those had been renewed. 4,138 were terminated for a reason that most of them, they were transferred to the marketplace. 21% were terminated for procedural reasons. And then as of 90 days later, which we've continued to bring this number down since January, of course, but as of the 90 days later, we were down to 11,000 who were still pending. And then this chart has a lot of information that probably, if you really want to dig into it, might be better to do not on a slide that's way up there. But just wanted to show that as of the month before the public health emergency started, we had 1,447,765 members. Our highest month was actually May. So a couple months after the public health emergency ended, we were at 2,231,726. And our most recent month of data shows that we are now at 1,990,822 members. And wanted to also go over, you've seen this slide before, but we keep it updated. So this is now our entire unwinding period, which was April of last year to March of this year. We did initially send those 700,000 postcards out. We also had 211 help us with 49,357 calls to individuals who were due for renewal to kind of explain to them what the process was and what they would need to do. We have sent out 535,347 warning letters. This is a letter for people who we hadn't been in contact with, and we figured they maybe don't even know what a renewal is. So kind of told them in a month, you're going to get this packet and here's what you need to do with it. If you have questions, here's what you can do. We've sent out 900,168 renewal packets to households, and that was 1,206,266 to members. We did 323,997 text messages, and we did those for individuals that it was past their due date and they still had not turned in their information. It was a reminder that they still had time to turn it in. The Division of Family Resources made 169,628 outbound calls to remind individuals to turn in their paperwork, and sent 141,759 emails. Again, a reminder to turn in the paperwork. We also did a special project with the Bureau of Motor Vehicles where we compared their address list to ours and sent out special postcards where there was a discrepancy to see if we could catch more people that way. So overall, FSSA has made 5 to 7 contact attempts for any person who came due for renewal to try and make sure that they knew what was happening and what they needed to do. And that doesn't even count all of the outreach that our stakeholders and partners have done, which we appreciate so much and has been so instrumental in the success of this process. And I am going to turn it over to Michelle.
Thanks, Nanis. Again, I'm Michelle Holtkamp, the Director of Communications for FSSA. I just want to take a few moments this afternoon to revisit the outreach efforts that we engaged in to raise awareness of the unwind. So on the screen are 2 examples of many of the materials that we provided to our stakeholders and partners to help them reach their clients. Our goal was to make sure that people knew that they would need to take some steps for the first time in as many as 4 years to retain their Medicaid coverage if they were eligible. We were committed to constant, regular, ongoing stakeholder engagement that is still underway today. We had broad meetings every 4 to 6 weeks, and we had targeted stakeholder meetings bi-weekly with key stakeholders who provided us real-time feedback about concerns and the experiences they were having with Hoosiers. And through that, we were able then to tweak our strategies or provide additional communications materials to help them serve their needs. We had intentional outreach to partners across the state, from food banks to YMCAs, pharmacies, et cetera, equipping them with what they needed to help us raise awareness. And then again, on the screen are just two examples of some of those materials. Cora, if you could go to the next slide, thank you. We also developed a robust website with FAQs, table tents, conversation guides, videos, sample mailers, and more. And this was just part of our commitment to robust information, responsive strategies, and transparency. We're really duplicating many of those same strategies now as we restart cost sharing in July for about 1 million Hoosiers. So first, just a quick review of some of the key dates and the timeline for the cost share restart. This begins July 1 for Hoosiers, the majority of whom are on HIP, but CHIP and MedWorks are also affected. In February, we began sending an updated insert in eligibility notices to let people know that this was coming. Last month and this month, we're sending the 60-day notification of cost share restart to members. Very soon in June, the MCEs will begin sending notices alerting HIP members to watch for the invoices arriving in July. And then in July, those invoices will be sent primarily in the first half of the month, again for HIP, CHIP, and MedWorks. And that would be for the month of August. And then in July, also, the copays will become active. On our website, we have provided sample notices that the members are receiving. And then we've also stood up a website for cost share restart. We are really trying to simplify this for our members and break it down into basically 3 questions. Do I have to pay? How much do I have to pay? And how do I pay? So we have sample flyers on the screen there that include a QR code that will take folks to our landing page. And then you can see an example also of a table tent that we're providing to our partners, again, to try and help raise awareness. We're still conducting stakeholder meetings with the same groups of people as we go through this process. We're building a social media toolkit and asking our stakeholders to use it to help us reach their clients. And then again, we will be using feedback from them and our partners to further refine our efforts and add new materials and strategies. Thank you.
Terry, do you want me to take questions or do you prefer whatever your preference is? You're fine.
Writing notes. Sure, yes.
Okay, great. I saw Senator Yoder with the question.
Thank you so much. And thank you for that presentation. I appreciate so much this strategy to communicate effectively in these steps with us. I have a couple of questions. So this happened pretty quickly in terms of when COVID hit, we expanded access and that happened fast, right? Like all of a sudden you had to deal with a Medicaid expansion. How many months have we been working on this unwinding? It's been 18 months, you think, or?
We started out when we had to expand coverage and stop allowing for any closures. We started out with the goal in mind of one day we will have to undo all of this. So I would say it's been in mind from the very beginning. We have been doing the renewals for coming up on 13, 14 months now. We're done with our actual unwinding period, but we are catching up on the extra work. But Michelle could probably talk more about all of the preparatory work that went into the communications plan, the stakeholder outreach.
I think it's just more of a comment in the amount of time, attention, dollars, a communication plan in this unwinding. And this is the comment. But for many families in Indiana, the way we changed the A&D waiver there was very little communication. We can see the amount of effort that it has taken to get it right in the unwinding, but we did not take that same care with our families and with people with long-term disabilities in Indiana when we made the decision to change the A&D waiver. And so many families still, I am hearing on a regular basis from people in my district. They don't know what's going on. They haven't had clear communication. And I think it's just strictly because we're moving too quickly. We've had to move so fast, and this unwinding has taken from the very beginning. You started thinking about how are we going to implement changes, and we just simply have not been able to give that courtesy and that level of communication owed to Hoosier families with this massive change that was announced in January. So I just wanted to sort of make that comparison, and I appreciate the sensitivity and the work and the amount of communication that has had to take place. Thank you. And I just ask that that same courtesy be extended to so many families when we announced that we were pretty much what felt like pulling the rug out from so many families in the state of Indiana, so many individuals. Thank you.
Thank you. Senator Cadora, then Representative Clear, and I also see Katie Stafford Cunningham with the question. So.
Thank you. I'll be brief. Thank you. My question on enrollment relates to the first few pages. The numbers that you presented are only limited to CHIP, HIP, and traditional Medicaid programs, or does it also include those who either qualified or disenrolled and then ended up being on the wait list for the A&D waiver?
So the wait list for the A&D waiver was not in place at the time when we were doing these activities. These numbers do include all types of Medicaid, age blind disabled, HIP, Hoosier Healthwise, Hoosier Care Connect, our Medicare savings program. So it's all types of Medicaid, including our emergency services only.
So potentially under the 52% of those who qualified to renew for Medicaid, is there a chance that there's a number of those individuals ended up being on the wait list for the A&D?
That is not a question that I can answer.
I'm sorry, Senator, ask that one more time. Individuals that were redetermined.
Whether they qualified for redetermination, they were, or they were disenrolled. How many of those individuals are currently either lost their services that related to A&D or got placed on the wait list for the A&D? Because I'm aware that I received constituent emails that they were individuals who were disenrolled in December of last year. Specifically, 2 cases, one of them mentioned that they were at an assisted living facility, memory care, a person who was physically able, but they had dementia. So they did not need to go to a skilled care facility or to be kicked out of that facility to go to a hospital. And the provider in that community has been providing free services for the last 7 months between December until, well, they expect until July, because that person was kicked out of Medicaid. So when I look at these numbers specifically, my question is, how many people that were kicked out of Medicaid or even approved, but later got placed on the ADN wait list and they're not receiving the services today that they need to receive?
So I'll just start by saying that obviously each situation is so unique. I hate to say a blanket, this is the path that someone would have taken in a particular eligibility situation. Is that fair and honest? Certainly with the A&D waitlist, I do want to just make one potential point of clarification, which is that no one was receiving services on the A&D waiver and then added to a wait list. The wait list is for new entrants to the A&D waiver. And so certainly, as Nana shared the number of ex parte redeterminations, it's possible that individuals would have had an ex parte renewal as well, where they would not have had to do the full redetermination paperwork. Each scenario, though, is so specific. I hate to kind of comment on those specific instances that you stated. I'm not sure that we have specific data available today about the A&D wait list. And individuals that would end up on the wait list that vis-a-vis when their redetermination was. It really would depend on, were they new to Medicaid as they were trying to come onto the A&D waiver? Were they already on Medicaid and just not on the waiver? Each sort of bucket would be separate.
I appreciate that. The follow-up question, how come we don't know how many people are on a wait list? If they were approved and they're just waiting on the A&D list, what is the obstacle to obtaining that information?
Oh, I'm sorry. I just meant we wouldn't, it's unclear based on when a person's redetermination was.
Got it.
We do have the data around the wait list.
Do you know how many people currently are on the wait list for the A&D?
We are working through the A&D wait list. It obviously changes on a daily basis as individuals are added to the wait list. And we're currently working on determining the sort of place within the wait list process that an individual is, but we will be transparent as we move forward with that. As far as once we have some clarity around the number of individuals who, I think as you're familiar, Senator, there's multiple pieces of eligibility, including the functional eligibility, their nursing facility level of care determination, their financial eligibility. And so we're parsing through who is in the wait list and what stage in the wait list process they're in. So more to come on that.
But can you give us a number and a general number, regardless of which stage in the process they are in? Because I'm hearing conflicting messages from my constituents and from providers. Some are telling me that their FSSA is kind of communicating there will be about 7,000 open spots for the A&D. Now, some of these folks are concerned, what if there are 15,000 approved individuals that need services? The 7,000 is not adequate. So the level of transparency that I'm asking for today, how many slots will FSSA approve? And then how many people are currently in the process that have been approved? So that at least from a legislator's perspective, who serves on the budget committee or the appropriations committee, I will be informed to advocate to be sure that these constituents have enough, that Medicaid has enough funding so that we can absorb the entire wait list. I don't think someone who's on dementia, someone who requires services because they are aged or disabled deserves to wait for 5, 6, 7, 8 months. And for the providers, the uncertainty of it comes July. If you have 7,000 approved slots, but you have 15,000 patients, then today, this on my way coming over here, one of the providers called and said, I had to write off the bills for this person, and it's been almost 6 months. And I might be able to write it off for a couple of more months, but comes July, if they have limited number of slots approved, but more people to qualify, what should I do? I'm going to probably shut down my business and move on. So that's so what are your thoughts about the number of approved slots versus the number of the people going in the pipeline for approval? Is there a mismatch, or are we around the 7,000 number?
I think that we will have additional, let me state this. In state fiscal year 25, we will open up roughly an additional 5,000 slots. So for state fiscal year 24, the number of authorized slots on the A&D waiver is roughly 50,000 and change. I'm sorry, I don't have the number off the top of my head. For state fiscal year 25, that amount increases to 55,000, and that's spread across what will become 2 separate waivers: the Pathways waiver for individuals 60 and over, and the Health and Wellness waiver for individuals 59 and under. And so that's the total 55,000. We are in the process of determining the split between those 2 waivers, where individuals are in the pipeline in terms of have they already had their nursing facility level of care eligibility check done? Have they had their financial eligibility determined, or both? And then are they just, is the last step being invited into the waiver? So we will be transparent with that, and we will be sharing additional information. I just hesitate to give data until we've done every check that we possibly can and made sure that in advance of July 1, we're clear and about where people fall in terms of that pipeline, and on which waiver they will end up being, so that, as you said, we can be very transparent with stakeholders, legislators, et cetera, around where individuals fall. And most importantly, so that we can give potential waiver members, Medicaid members, an indication of what they should expect moving forward, what steps they can continue to be taking as they're waiting on the wait list. And I'll sort of use this as an opportunity. Senator Yoder, really appreciate your comments as well. And so these are the types of things that we are addressing in weekly member newsletters that are now coming out around the A&D waiver and our waiver transition activity. We're holding bi-weekly family webinars for families. They're the waiver members themselves, caregivers, et cetera. Providers are also on those. Those are open to the public and posted online. And so we are trying to very much ramp up our communication so that we can give individuals a little bit better picture of what is to come on some of these issues like what you're raising, Senator
I
Godoy.
appreciate it. And I would hope to hear back from you guys before July on the number of not only the approved, the 55,000 slots, but how many people actually will be considered for the program so that we can act if we need to on the General Assembly side. I'll conclude by sharing with you a comment about, I know, and I, as a former employee of FSSA, I appreciate the nuances and the complexities. But I'll share with you, in the last week, for example, one of the cases that I've heard about is a person that has been spending down their assets so that they can qualify for the A&D because they are aging, they are unemployed, and their assets are limited. So they've been benefiting from going to a certain provider to get that services. And then when they applied for the A&D and waiver, they were placed on a wait list. So now after they depleted their assets, they have no more assets, they qualified, but they're not getting the reimbursement or the coverage by the state Medicaid program. These individuals are now being put in a very difficult position between the provider and the state. The provider is at the point of, I either have to discharge them to the hospital, which is much more expensive, and hospitals are not the right places for them, or a skilled care facility, which is triple what they can pay or they currently pay for assisted living. And the person is struggling emotionally to understand who's going to pay for their healthcare after they were told if you deplete your assets, you would qualify for this program. So there are real life implications on citizens and providers. And while I sincerely appreciate the communication, I think we need to double down on the efforts and expedite the work on this to whatever magnitude to be sure that we're assuring these families that the state did not leave them behind.
Clear.
Thank you. We got into a discussion about A&D waivers, but we have pathways on the agenda. So can we come back to that
Yes.
at the appropriate time on the agenda? I have a number of questions, but I
Sure.
wasn't going to get into it at this point. So first, I want to acknowledge OMPP for the work that has been done to reduce disenrollments. I'm pleased to see I don't know which the slides are numbered, but the graph that showed the three lines, the blue, the gray, and the green. So that represents some good work. I'm, as one of the MAC members who expressed a lot of concern at the outset of the unwinding, I wanted to acknowledge the good work that's been done, but also express concern about the members who were disenrolled earlier in the unwinding. It's good to see that final month, March of this year. Good to see that it dipped below 10%, right? But we started out closer to 35%. So several questions. One, what, if any, outreach or other efforts have been conducted to go back and try to identify folks that might have been caught later in the unwinding, but fell through the cracks earlier in the unwinding? So that's one question. If my numbers are correct, I'm looking at the slide that shows the Medicaid enrollment change during unwinding. That's the title of the slide. From February of 20 to April of 24, we went from a little less than 1.5 million to a little less than 2 million. That's total Medicaid program enrollment, right?
Correct.
So if my math is correct, we've seen a 38% net increase in Medicaid program enrollment across all of the programs combined from the beginning of the public health emergency or the period immediately preceding the public health emergency in February of 20 to April of 24. And then I've got to find the slide. So again, I want to acknowledge OMPP for its efforts. Indiana, along with Tennessee, adopted the highest number of 1902 E14A unwinding waivers. So we adopted 15 waivers / flexibilities. Let's see, Ms. Spinner, you talked about the 90-day reconsideration, and I know I raised the question at a previous MAC meeting regarding the ambiguity around the 90 days as it relates to HIP 2.0, and I had asked for an opinion on that. So I wonder if there's been any more effort on that. But regardless, was there any consideration of an unwinding waiver that would have allowed HIP 2.0 members to take advantage of that 90-day reconsideration? So I may have some more follow-up, but that's enough for the moment.
Sure. So HIP members are eligible for the 90-day reconsideration period. It's just that because the state law does not give retroactive.
Oh, it's the
coverage, so
retroactivity.
they can come back, but it only goes forward.
Sorry, I'm conflating the issues. So the question I had raised previously was regarding the ambiguity around retroactivity. And I had asked OMPP to revisit that because I've heard conflicting opinions on whether in fact we have the ability to provide retroactivity. With that in mind, I'll change the question. Could we not have had a 16th waiver that would have allowed retroactivity for the folks in HIP 2.0 as part of the unwinding?
I think, and Cora, you can feel free to correct me if I'm out of my depth. The waivers that we were offered were for federal requirements and would not have applied to state requirements. And that would have had to been something done within Indiana, I believe.
That's correct. So those individual flexibilities were each CMS level flexibilities of certain federal regulations that CMS offered states to apply for a waiver for those items. So state level laws could not be waived by that entity. And so that's why they're not really in the bucket of the 1902E waivers. The current interpretation is still that state law, explicitly disallows that retroactivity for the HIP program under Indiana code.
So has someone taken another look at that since I raised the question?
Yes.
And is there a memo or an opinion, an advisory opinion, or some sort of document that you could share with?
We're happy
with the
to
MAC?
point to the citation. I think that is the basis for that.
You talk about the code citation?
Yes.
So I think what you've relied on previously, I forget what the public law number was, but I remember the bill all too well. It was Senate Enrolled Act 165. That's what it goes back to, right? Back in
I'm not
20
familiar with the,
It was 2016.
okay.
So is that the basis still?
I think it's a particular provision of Indiana code, but I'm happy again to
Well,
provide.
that's what I'm asking. Is that where the provision and code that you're relying on came from?
I don't have it off the top of my head, so I would hate to tell you the wrong information, but we're happy to point to that. And after this meeting can chat with you.
Okay. Yeah, I'd like to have the code citation. So anyway, I'm sorry, Ms. Spinner, go on, please.
Oh, I appreciate all of your comments. You may have to refresh me on the questions beyond the retroactivity for HIP. I think you had asked, sorry, I'm trying to.
Well, that's okay. So what you're saying in this slide regarding unwinding renewal activities is that Indiana and Tennessee are tied for adopting the highest number of the federal flexibility waivers, meaning we adopted more of we took advantage of more of those opportunities than 48 other states
Yes, and a few territories.
and a few territories. Interesting. So again, I really commend OMPP for taking advantage of that. And I think it is obviously reflected in the graph that shows the steady decrease in disenrollment. But I think to refresh you, my earlier question was what outreach or other efforts have been conducted to go back to those folks. You know, we had a third being disenrolled at the outset of unwinding, and then thankfully it dropped below 10%, which is great. But maybe not as great for the folks who were, you know, just by luck of the draw early in the unwinding. So have we done, or are we doing any outreach or other activities to try to go back and make sure that those folks who were disenrolled, who might not have been disenrolled, had their redetermination been had the timing of their redetermination occurred later in the cycle? Does that make sense?
It does.
Yeah.
We also recognize the layering effect of communications was having some impact, and the numbers of people being disenrolled was dropping, but what to do about the folks who were disenrolled earlier in the process. So this is an example of one of the methods that I referred to about constantly tweaking and developing new materials. And one of the materials specifically that we drafted was what to do if you've lost coverage. And there were 4 or 5, and I'm sorry, I can't remember exactly what all they are off the top of my head, but there are 4 or 5 different steps that we outlined for folks, and we used QR codes. And then we again asked, yes, there it is. I cannot possibly read that small print. But we then have continued to ask our stakeholders to distribute that to capture folks who have lost coverage.
So is that being mailed out to all the folks who were disenrolled earlier in the cycle? Or has it been mailed out?
We have not mailed that out. We've instead, again, relied on our trusted community partners who have relationships with folks in the communities.
But do those community partners don't have the list that you have? I mean, you know exactly who was disenrolled.
So one of the waivers that we took up, the federal waivers, was to allow our managed care entities, which I believe were about 85% managed care. Normally, when someone is disenrolled, the managed care entity loses their ability to talk to them because they don't belong to them anymore. So we took a waiver to allow them to reach out to individuals who'd lost coverage to, you know, capitalize on our shared interest that we all want them, if they're eligible, to keep their coverage. And so they received lists of everyone who's due for renewal, and then they received lists of everyone who was disenrolled. And so they did specific and targeted outreach to their members to try and encourage them to come back into coverage and to give them assistance in doing that.
To their former members.
Right.
Right. So are you confident that they provided this to 100% of their former members?
I believe they were making personal phone calls and doing other mailings to them. I don't know that they may have used this material, but to my knowledge, it was a personal phone call from a human being to another.
Okay, but you're confident that the MCEs were taking steps to communicate with 100% of their former members who were disenrolled as a result of the unwinding?
I am, because they were very motivated to keep those individuals in their plan.
Okay, well, that's great. Let's see, what else? Is my number 38% correct?
We could do the quick calculation here.
I mean, that's the math that I came up with. So somebody check me. But rounded, I'm showing a 38% increase from before the public health emergency until now in net Medicaid enrollment across all programs. And then my last question, I know you said Katie Stafford Cunningham had a question as well. So
If you don't mind, Representative Clear, this might be a perfect time to ask, because her question kind of aligns with that 38%, which was
okay, go
not
ahead.
as, what do you attribute the additional 400,000 people to who are currently enrolled versus pre-pandemic? Like anything you want to comment on from a policy standpoint that might be driving that net increase over time? Thank you, Representative.
So we've seen the greatest change. We were losing, not losing, but disenrolling around 20,000, 25,000 a month before January of this year. One of the biggest changes was that we adopted continuous eligibility for children up to age 19. And so while it did not change, it didn't really impact the metrics of our renewal activities. The continuous eligibility means that between when you get approved and when your renewal is due, those 12 months, you cannot be closed when you have a change in circumstances, even if you are over the income limit. So the add-on effect of this report, which isn't specific to renewal, it's our total enrollment, shows that we are not disenrolling children in the middle of the year. They are keeping their coverage until that continuous eligibility period ends when their renewal is due. And so we do see that there is a smaller change in enrollment each month, due in large part to those children who are keeping coverage.
Last question on this topic regarding the cost share restart. So it's the MCEs that are conducting the communication, right? The notices that are going out to members.
I would say it's layered. We have on the page that you're looking at, let me get there and we'll be looking at the same thing. So the first item we have there, the insert, that is included in every eligibility notice for someone who's on Medicaid that comes from FSSA. The 60-day notification of cost share restart, that also was an eligibility notice, so that comes from FSSA.
Right.
The MCEs are sending those notices to actually HIP, CHIP, and MedWorks members. They're sending postcards in early July, so that will come from the MCEs, but also for our fee-for-service population, FSSA will be sending those out to make sure they're not missed. And then those invoices that are going to go out in July for August benefits, HIP is administered by the MCE themselves, so they will send those out. For CHIP and MedWorks, we have a premium vendor, and so those will come out from the premium vendor.
Yeah. Well, regarding the power account contributions specifically, we know historically that a large percentage, if not a majority of power account contributions have been made by third parties. So family members, nonprofits, churches, others. Have there been any outreach activities to try to make sure that those third parties are aware? Because I'm concerned that some HIP members whose financial responsibility has been covered in the past by a third party may not be as aware as they need to be of the consequences of failing to meet that financial responsibility upon the restart. So
I can start on this one, Michelle.
Yeah.
If you want to jump in. So we've had one specific stakeholder meeting that was focused on cost share restart. We have another one that will be coming up in the next month or so. And we've got a website, the QR code goes to, that is very specific. It has by MCE, what are all the different ways that you can pay, including if you're a third party payer, what are the ways you can pay? Lynn and her team have reviewed the scripting that the MCEs will be using if someone were to call and ask them that question. So there is a lot of information out. And again, we'll be having another stakeholder meeting that we would encourage anyone to attend. And we'll publicize that on our Return to Normal website.
will there be any additional grace period for non-payment?
The standard grace period is 60 days.
Right, but will there be any additional grace period upon the restart? Or do we have that flexibility?
I think that's something we'd have to take back and explore and discuss. I'm not sure if that is, to what extent that's in code versus something administratively that could be considered, but it's worth exploring.
Yeah, I think that relates to Senate Enrolled Act 165 as well.
Oh,
Perhaps.
okay.
Yeah, I hope you will take it back because I just think it would be, well, it would be a shame for someone to lose coverage because they miss their first $2 or $3 power account contribution upon the restart. And turns out to be somebody who had never made their own contribution, but rather the contribution was made by a third party, and that third party is not aware of what's going on, and then the individual loses coverage because of a couple dollars. So please revisit that and do what you can.
And you are probably aware of this, but just for anyone else who is not as familiar with the HIP program, individuals who are under 100% of the federal poverty level, if they don't make their payment, they do not lose their coverage. They move to a basic program coverage, and then they can buy back up to plus at their next renewal. So it's not everyone will lose their coverage. And we also, just to get this out there, because there are still some people who aren't aware that we do not have lockouts in HIP any longer. So if someone loses coverage, they can immediately reapply. They do not have a 6-month period where they're not able to get HIP again.
So the folks who are most vulnerable would be those between poverty and 135% of poverty.
Those would be the
who are in.
individuals for whom the payment is mandatory, yes.
Right. Okay. All right. Thank you.
Thank you for the questions. Any other questions? Okay, great. I think we're ready to then transition, switching gears a little bit. We are joined by I'm going ahead too far. Members of our clinical operations team within OMPP to provide an update around the IHCP Quality Strategy Program. We are required to present this information at a public meeting such as the MAC. And so very happy to turn it over to Kathleen Dillinger, who is our Director of Quality Improvement.
Good afternoon. Thank you, Cora. As Cora said, my name is Kathleen Dillinger, and I am the Director of Quality Improvement within the Clinical Operations Department at OMPP. Today, I will be providing an overview of the proposed Medicaid Managed Care Strategy Plan. So first, I'd like to give you a little bit of a background. States that contract with managed care entities to provide Medicaid services are federally required to establish and maintain a quality strategy plan. Quality strategy plans must be renewed every 3 years or sooner if there are significant changes to the Medicaid program. With the implementation of the Indiana Pathways for Aging waiver, the current strategy plan is being renewed. The anticipated effective date of the plan is mid to late June 2024. Part of the renewal process is for OMPP to obtain input from participants, key stakeholders, and the public prior to submitting the plan to CMS. This includes presenting at the Medicaid Advisory Committee. The purpose of the Quality Strategy Plan is to outline Indiana's Medicaid plan for improving the quality of healthcare services provided through its managed care entities. It is the expectation that managed care entities take into consideration the state's quality priorities and incorporate them into their quality improvement programs. The Quality Strategy Plan specifically directs the managed care entities to OMPP's quality goals, objectives, and targets to obtain these goals. An example of how goals are identified by OMPP and incorporated into the Quality Strategy Plan is as follows. Let's say over time, OMPP notices that there is a decrease in the number of people completing a particular preventative screening. Since this is a concern, OMPP puts a goal into the Quality Strategy Plan to improve the number of people who complete the screening. Objectives and targets are set and are also included in the Quality Strategy Plan. It is the responsibility of the managed care entities to conduct quality improvement activities to meet the goals and objectives. It is the responsibility of OMPP's Clinical Operations Quality Improvement Team to monitor performance towards the quality goals. Next slide, please. This slide just provides a brief overview of the Quality Strategy Plan development steps. Currently, we are in the public period for the Quality Strategy Plan. The public comment period ends this Friday, May 24th. Any comments will be reviewed and taken into consideration prior to submitting to CMS at the end of the month. Next slide, please. There are 3 key changes that I want to point out that are part of this Quality Strategy Plan. First, I wanted to take this time to say what the 3 major changes are. One being that the changes were due to implementation of the Indiana Pathways for Aging program. 2, quality improvement revisions were made for all care programs. And 3, quality management updates, including enhancements of performance monitoring. With the launch of the Indiana Pathways for Aging program On July 1st, several edits needed to be made to the quality strategy plan to incorporate quality oversight for this new program. This included adding general information on the Indiana Pathways for Aging program and program-specific goals and objectives. In addition to adding requirements specific to the Indiana Pathways for Aging program, OMPP also revised the goals and objectives for the current managed care Indiana health coverage programs. Healthcare quality priorities were identified based on specific state needs. More information about the revised quality strategy priorities will be presented in a later slide. Revisions were made to the quality of care components, include outlining new state-directed healthcare performance improvement projects, outlining pay for outcome measures, and establishing health priorities for improvement. An example of a state-directed performance improvement project topic is improving satisfaction with healthcare services. When referring to pay for outcome measures, the focus is on how the managed care entities can earn compensation for meeting certain conditions that drive quality improvement and improve health outcomes. To improve the management of quality, an interagency quality improvement work group has been formed to focus on quality activities across all FSSA waiver programs. OMPP is committed to providing robust oversight of the managed care entities and their quality performance, including increasing the number of performance measures being evaluated as part of this revised quality strategy plan. The revised plan includes new quality measure categories that will promote more active, timely evaluation of managed care performance. We'll review this revision in more detail in the next slide. There are 4 category measures that OMPP has identified to monitor managed care performance. These include early indicator metrics, watch metrics, process and outcome measures, and pay for outcome measures. So what does this performance monitoring look like for our members? Let me walk you through a scenario. Through routine performance monitoring, OMPP notices an increase in complaints about members not being able to get an appointment with their doctor. This could be considered an early indicator and has the potential to impact the member's health care. We look further at our process and outcome monitoring measures and notice that there is a decrease in the number of children and adults completing their wellness visits. As a result, we work with managed care entities to help ensure that members can complete their wellness visits. We then watch to see if there are less complaints and more members completing their wellness visits. Over time, we discover that there are less complaints and more members successfully completing their wellness visits. This is just one example of how the performance categories can be utilized to monitor and improve performance. Now that we have reviewed the quality measure categories and an example of monitoring, we will focus on the quality priorities. As mentioned earlier, OMPP has identified healthcare priorities areas with input from the Division of Mental Health and Addiction, Indiana Department of Health, Bureau of Disabilities Services, and Division of Aging. The interagency collaboration ensures that key state health initiatives are incorporated into the quality strategy plan. OMPP and FSSA are committed to improving the lives of Hoosiers to reach their greatest emotional, mental, and physical well-being. To achieve this vision, OMPP has established 5 pillars of well-being, with each priority area having its own goals and objectives. For the calendar years 2024 through 2027, which is the 3-year timeline for this quality strategy plan, the priority areas that OMPP will focus on include behavioral health, maternal and child health, oral health, chronic conditions, and care coordination. The 5 pillars were developed based on review of state and national data, state health initiatives, input from external partners, and needs of the population. The goals and objectives for each pillar are measurable, take into consideration the health status of all populations in the state served by the managed care entities, and were determined based on a review of quality metrics, pay for outcome measures, external quality review recommendations, consumer surveys, and trends in healthcare data within the state. OMPP expects managed care entities to incorporate the 5 pillars into their quality improvement programs as outlined in the quality strategy plan. This concludes my presentation on the overview of the quality strategy plan. As a reminder, the next step will be that the public comment will end this Friday, May 24th, We will then take into consideration the feedback and update the quality strategy plan as needed. OMPP will be submitting the quality strategy plan by the end of the month. Please feel free to reach out if you have any questions. Thank you for your time.
Any questions for Kathleen, Senator Yoder?
Thank you. Thank you so much. I appreciate the information. My question really is on the quality standard requirements. I see on slide 20, under care coordination, one of the bullet points is to deliver person-centered services and supports. But my concern is all of the person-centered approach is expected but not required. So how can the state make certain that it intends to have that high of quality of services, that it is person-centered all the way, and not just I mean, this is just not just one bullet point under one pillar that's just expected but not required. Because Cora did say earlier, each situation is unique, each person is unique. And especially in this, when we are rolling out something that I know that my constituents received the general letter, and people are genuinely, and I think appropriately, very afraid of what's going on because they have advocated for themselves and received that kind of care from the program as it currently is, and have, their providers established, and they are very concerned that there isn't going to be a desire on providers to become pathway providers. So how do we make sure that we have that person-centered approach with the Pathways program?
And Senator, I'm sorry, Senator, I didn't mean to cut you off. One quick point of clarification. This is about the quality strategy, the 3-year quality strategy plan.
Mhm.
We're going to get to the Pathways presentation in
Okay.
just a moment. Anything though that you want to touch on, Gio, about person-centered planning and quality as a whole?
Because it does connect, but how do we make sure that person-centered is in every pillar and not just under care coordination?
So there'll be two Medicaid populations, those that will be in the Indiana Pathways and those that are not. For the Indiana Pathways, we'll go into details on how that is actually a requirement in their contract. For the non-Pathways population, there's actually one of the metrics that we measure is a HEDIS measure that talks about transition of care and care coordination. And there's a lot of requirements around that. So that is one of the measures that we're looking to see how the states perform, the individual MCEs. And that's one of the quality measures that we'll be monitoring as well.
Are we also monitoring? I have heard that the service coordinators have to be in Indiana. Correct?
Correct.
I'm sorry, maybe we could just hold that question. We have a more robust presentation on Pathways, and we'll be talking about service coordination specifically. So if you don't mind, we will definitely get back to that question.
But could our quality strategy also include that our care coordinators also be in Indiana? I mean, that would be part of the care.
They do today.
They do, and they will be required to be in Indiana.
They are required today
The care coordinators,
to do their jobs in Indiana.
they have to be in Indiana.
That's what I was going to
Awesome.
clarify,
Thank
that
you.
to be. Yeah,
Oh.
there was a lot of discussion of that, Senator Yoder, during the legislative session, as you may recall, because many of us were concerned about requiring them to live in Indiana. They will not be
The care
required.
coordinators do not have to live in Indiana.
In anyone providing, correct me if I'm wrong, but I think where we landed is that anyone providing services under an MLTSS contract has to provide those services in Indiana, but they don't have to reside in Indiana. Is that accurately stated?
That's
Okay.
correct.
And I think there's still some ambiguity that I would like to see resolved around work from home and things like that, because my AAA, as we've discussed, has folks who live in Kentucky. They may live 15 minutes by car from Lifespan's office in New Albany, and as a result, be closer in geographic proximity to Lifespan's office than somebody who lives in Jackson County for whatever reason and works for Lifespan. But I think there's still some ambiguity around work from home. If there were reporting functions, for example, that could be appropriately performed in a work from home scenario, will they be allowed to do that? And I don't know how we would even monitor it, to be honest, but it's a question that I think has to be resolved at
Sure.
some point.
Yeah, well, we can go ahead and answer this, but
Yeah.
then maybe we'll try to move forward with the pathways presentation.
And I think it was just that they need to be close enough to access Indiana. Majority of our folks that are receiving the services live inside Indiana. So the expectation would be that they're close enough that they can get into Indiana and that they're part of the communities generally of the folks that they're serving. Now, I use Henderson, Kentucky because that is the easiest geographic to show, like, you've got tons of people who work inside of Evansville but live in Henderson, Kentucky. That is because that's their community. Evansville is part of their community. Henderson's part of Evansville's community. So that's permissible. Yeah.
Let's put a pin in this, but I appreciate something you just said. I forget how you phrased it, but you said that we want them to be familiar with the communities they're serving, the service providers. And that is a growing concern in light of the breakdown in negotiations with the AAAs. And I'm very concerned, and I think many others are very concerned that we're going to begin to lose that community familiarity very quickly as the MCEs scramble to have warm bodies in place by July 1. And that may not be someone who has any familiarity with the community where they're doing service coordination or other functions. So put a pin in that, please, and we'll come back.
Sure, we'll get to that when we get to the pathways presentation. Any other questions around the quality strategy plan? If not, thank you, Kathleen. Okay, now we have arrived. We've made it to our destination in the pathways presentation. So we're joined by a number of OMPP staff members, but I'm going to first introduce, and I think Holly Cunningham Piggott is going to kick us off here. Holly is our Director of Care Programs.
Thanks, Cora. This a little bit closer. Okay. So if you want to. So we're going to cover a few topics here. I'm going to go over the enrollment process, the readiness review, and claims testing. And then I'll pass this off to Gio, who will then go over complex care transitions and service coordination. And then Kim Bremer will be going over the resources and stakeholder engagement. Okay, so our pathways enrollment. This is where we're at today in May of 2024. And where we will be by July 1. We have sent out members a 60-day pathways enrollment notice. They received an enrollment notice sometime between the end of February and the end of March. We sent them out in a wave of over a 4-week period. And now we're into 60 days pre-go live. So now we have sent out another letter to members letting them know about the pathways enrollment and how to connect with their benefit plan, health plan, or if they need to call and be enrolled in a health plan, then it gives them the information on how to do that. Starting in June 3rd, to be exact, the MCEs, actually during this month, they're receiving enrollment files from us. June 3rd, they're going to start sending out welcome packets to those individuals who are enrolled with their health plans. And in those enrollment packets, it will include their the member ID card. It will include how to contact the member services. It will have the handbook and other information for them. And I think really one of the more important pieces of that is how to contact the MCE. And then July 1st is when coverage will begin, and those fee for service or Hoosier Care Connect folks will then transition into the Pathways program. Okay, slide. I want to just kind of quickly touch, I just talked about the 60-day go live letter, but individuals have the choice of MCEs all the way up to go live and then 90 days past go live. So in that 60-day letter, it included the enrollment brokers information, and that's how so if they got a letter saying today you're assigned to Anthem and that's not what they wanted, then they can call the enrollment broker at the 87 pathway 4 number and have them move them to the MCE of their choice. And then they will have the ability to switch MCs up until 90 days past go live. So for the first 3 months, they can switch to the MCE. If they were assigned to an MCE they weren't sure about, they can move if they need to. They were all individuals too, real quick, that we did auto assign. Anyone who did not pick a health plan by May 1st was auto assigned. And if you want to go to the next slide. Yeah. We use the auto assignment logic. So basically, if they were already with a health plan in some sort of previous role, whether it's the Right Choices program, or maybe they're assigned currently to one of the Medicare Advantage plans under the current MCEs for Pathways, or their PMP is in network for that health plan. It went through this assignment logic, and if they meet the criteria outlined in the slide, then they would be assigned to that MCE that kind of fits that criteria. If they don't meet any of this criteria, then it kind of goes to a default round robin assignment, and then they're just kind of then they're assigned at that with that method. And then that's where, if they aren't happy with that assignment, it is really imperative that they give that enrollment broker a call and we can get them moved. Let's see. I think I already covered what's on the next slide. Basically, they have, again, kind of the more important piece here is they have 90 days past go live to change their MCE. They also will have other times throughout the year to change their MCE if they choose to, especially our dual members. If during open enrollment, if they choose a Medicare Advantage plan that is not aligned with their Medicaid plan, then they can change their MCE at that time. They can always change for just cause. So let's say their provider is no longer in the MCE network. That's just cause to move them to a managed care health plan that is in network. So there are other times that they can shift and change MCEs. Okay, readiness. So readiness is our lengthy, systematic, large-scale review of our MCEs, and to ensure that they are ready to go live come July 1. We want to make sure through our readiness process, are they ready to receive that enrollment file and start serving members out of the gate July 1. We review thousands and thousands of documents, and then we spend hours of watching demonstrations. Every other month we have them do, every month we have them do live demonstrations of different systems. So, and I'm just looking at the pharmacy. So 1 month it was the pharmacy. They had to show us their system in the pharmacy and how they pay certain pharmacy claims. 1 month it was quality. 1 month it was care coordination and service coordination. So they had to demonstrate all of their systems, and it was in a test environment, but what it would look like at go live. And then of course, there's lots of documents and policies and procedures that we do desk reviews on as well. We are wrapping up readiness. We are done with all readiness activities this month. We've roughly reviewed about 270 actual contract requirements with the MCEs. Almost all of the MCEs are over 90% compliant with readiness requirements. And by the end of this month, they should all be 100% through the readiness process. There's some outstanding documents that they're still submitting for review or resubmitting. Maybe we needed them to take it back and take another look at something, but we should be wrapped up completely at the end of this month. And I can say for sure that the MCEs are ready to take on this population. They have worked diligently with us as OMPP. They've worked diligently amongst each other to really try to figure out how to align processes and make this a little bit more of a fluid transition, especially for providers and members. Right now we are, and I'm going to talk about this in a second, we're working on how to make sure that claims submission, it may not be 100% exactly the same to submit, but things that go in a claim, we're making sure that all three MCEs ask for the exact same thing, so we don't have different MCEs requiring different things for different fields in the UB04 or in the 1500. So those are things that we're working on with our claims work groups. I think we can actually go ahead and jump over there if you want. So we have our claims submission testing, which was part of Senate Bill 132. One of the things in the Senate bill was that we convene a work group that included OMPP and then member representatives from different provider groups. And so we have two nursing home providers on our work group, two home health providers, hospice provider, two waiver providers, and I think that's it. And so they've been providing us feedback on where, what some of the pain points are with working with the MCEs, and then really providing realistic expectations for like those HCBS providers, those waiver providers that have never worked with a MCE before. So we've gotten some really good feedback from them. We have, as a result of that, have put things in place or recognized where we don't know what we don't know. And until, we kind of have these groups talking to us, now we know where we need to start, implementing processes or issuing guidance so that claims submission is aligned across all three MCEs, if not also aligned with Gainwell. So where we can align with the fee for service, we are, and where we can't, we're just making sure that the three MCEs are aligned. We have started, so as part of the Senate bill too, we were asked to create some sort of uniform billing format, which we're working on with the work group and with the MCEs. We are seeking feedback from our work group members on the testing and claim submission period. And then we're also being advised on where we can provide additional training and education to providers and to the MCEs. And then we're just trying to really define what does a clean claim or a claim submitted appropriately mean. We need to come up with a definition so that all three MCEs are following that same practice as well. Providers who participate in the claims testing with the MCEs will have access to emergency financial assistance. And I want to make sure that I clearly state that the emergency financial assistance is a prepayment, pre-claims payment, 80%, I believe, of an outstanding claim that has not been paid within the adjudicated time frame that is in the MCE contract. They have access to get prepayment of that claim. And then once everything is rectified, the MCE and the provider will then reconcile what the outstanding amount is on that claim once they have worked through what the issue is. So the financial assistance is to provide some relief on claims that may be stuck in some process, which, I think anybody who's ever worked for a provider knows, like, there sometimes are the weirdest glitches that no one ever thought about that's got a claim stuck for for several weeks, that's not been paid. So this is to help kind of alleviate some of that, anxiety about not receiving payment, because of a claims issue. Right now, we are in the middle of claims testing. It started on April 29th. We did a first window, which actually kind of just bled into the second window. But we started our first claims window from April 29th to May 10th. And then we kind of took a week off so we could analyze the data. And now we're in our second testing window right now. And providers are registering with the 3 MCEs to, if they would like to test claims. So as of last Wednesday, we have had about roughly 800 on average, 800 providers register to test claims between the 3 MCEs. And then we've had on average about 250 claims submitted through the test claims process. And now they're just working through what were successful claims, what were maybe rejected claims, what were denied claims. They're doing working like one-on-one with each of those provider groups. If it was successful, then they're letting the provider know that their tests were successful. If they were not successful or they saw issues with the claim, then those are the ones that they're providing technical assistance to and having them retest, so that we can get them ready to go for day one. And that is my last slide. Yeah, and we will let, the MCEs have stated that they actually want to continue doing claims testing until go live. So for us, we've made 2 windows, but the MCEs have made it known that they plan to continue testing all the way up to go live, and probably after go live, I would assume too.
Really quick on the readiness program, how many of the contractors or the providers have the providers universe were you able to contract with? Is there a percentage, and how many of them are pending? Because by July 1st, we're talking about almost 40 days roughly speaking.
Yep.
Are the providers ready, aside from testing claims, are they ready to turn the switch on and start serving on July 1st?
So the providers are already serving this population.
Right.
The difference then would be who the payer is moving into July 1. We just did a month-long road show across the whole state where we spent like 3 hours on pathways only topics. And then we do a stakeholder group every other week. We're doing a provider targeted work group once a month. And then we have our claims testing work group every week. And so we're providing lots of opportunities for providers to join and be educated on pathways. As far as where the MCEs are with their provider networks, they are required to have a provider network for the first 2 years. I'm sorry, they're required to have an open provider network for the first 2 years. I forgot the word open in there. And so any provider that submits a claim, whether they're in network or not, they have to honor, and that goes the same thing for prior authorizations as well. And then it's also any willing provider that wants to contract with them, any willing LTSS, long-term services and supports provider who wants to contract with the MCE has to contract with them for the first 3 years. I don't want to say our hope because I hate to make that a strategy. The outcome of this would be that they would have an idea by the first 2 years of the program of who their members are seeing and who they need to get into their networks. So that by the time 2 years comes up and they can prove that they meet network adequacy and request to close it, then we can approve to close it. If they don't meet network adequacy after 2 years, we still won't allow them to close their network. They'll have to keep it open.
I appreciate that. I'm going to hold off on a couple of more questions because I think your next section of the presentation specifically talks about the transition service coordination. I have questions about, AAAs and a bunch of other things. So I appreciate you asking. I'll wait till you finish the next section of the
I
presentation.
gave you a very winded answer. Sorry about that.
No, I appreciate it. Thank you.
Yeah, I have questions as well, but I think we should move through the rest of the slides before we
Yeah.
dig into those.
Thank you. I have a question about slide 26 and 27. Can you explain, it sounds so defensive already, but to me, the last line on slide 26, individuals can change their health plan anytime between now and up to 90 days after go live, is in direct contradiction to the first line on page 27, which says member always has the right to choose their pathway health plan. Can you explain how those are not contradictory?
Because so this was in reference to the auto assignment, and once they're auto assigned, they always will have 90 days to change after they make auto assignment. Now, the other, if you go to the next slide, these are the other reasons why someone may be able to change their MCEs, and it could be because now they're not aligned. It could be that just cause. So just cause is kind of like a very broad, a broad definition, but it could be because maybe someone's wife went from being with fee for service and now they're with United, but the husband's with Anthem. That's just cause to move the husband to United with the wife. There's obviously anytime they change their Medicare, if they're moving into a DSNP or they're moving from one DSNP Medicare Advantage company to another, that's another reason that they can switch. So there's lots of other times within there that someone can choose to change their MCE.
It does say always, so.
It's a good point. I think maybe a better descriptor of this particular slide is always have the right to choose after being auto assigned.
Okay,
Since this slide is, we probably could have labeled this slide a little bit more clearly, right?
Yeah.
So this is about choice related to auto assignment.
but only 90 days after being auto assigned, would they always have the chance to choose their pathway health only within that 90 days? And then they would have to have just cause.
No, not for the first 90 days. It would be after the 90 days.
That's
Yeah.
what I mean.
Yeah.
Yes.
After
Right.
90 days, and after 90 days for just cause or, one of these
Other,
circumstances.
Yeah,
so not always.
And
But-
of course, during the annual,
they'd have it on their annual redetermination date. They have it
Okay.
there during their annual Medicare enrollment date. They would have it for just cause if there was some thing that met just cause definitions. I mean, there's actually, they can change their plan 4 times a year. And as it's written today, they can switch NCEs 4 times a year that are outside of just cause.
Mhm.
Yeah.
So the challenge will be making sure that these MCEs are working just 24/7 around the clock to ensure that their members have their providers that they're currently on that MCE. Because a physical therapist might be, sign up to Humana,
Mhm.
and that person's endocrinologist happens to be in United.
Mhm.
So yes, they're all participating, but that one member, all their providers have not lined up. So it's,
And that's where care coordination comes
Yes.
in play too. I mean, this today and today with Hoosier Care Connect and Hoosier Healthwise, there are times when people transition into the plan and might have a PCP that's with United, but they're maybe one of their major specialists, heart specialists, is with Anthem. The care coordinators work with them to decide, would you rather us help you find a PCP that would be in network for Anthem? Or would you like us to find you another heart specialist that would be in network with United? That's what the care coordinators assist our members with as well.
and for the first 2 years, less of an issue.
Yeah. And
Because of the open network.
the open
Yeah.
network will definitely help.
yeah,
So certainly something we need to monitor
Yeah.
and have the opportunity in those first 2 years for the care coordinators to be looking at the members assigned to them and working through any issues, especially as providers are they're seeing an out of network provider, the care coordinator at the MCE is going to need to be thinking through strategies and the like, whether that's working to bring that provider into the network or providing, as Holly said, some really enhanced care coordination to ensure that member can be seen by the provider of their choosing.
I know that, I mean, here I am, I'm trying to figure out when is the best time to ask my questions. I can't even figure out, like, is this the best time to ask a question or later? You'll tell me, I'm sure. So my question is, when we have our 3 MCEs, let's just say there is because I read the letter that went out to members and it just highlighted, very small font, I will add, examples of the kind of care. And let's just use, for example, the vision coverage. It was different for every MCE. And vision and the hearing, just how it was articulated on that letter was different for every MCE. So if somebody's saying, well, I have unique vision needs, I have unique hearing needs, my hearing needs seem like they fit best with Humana. My vision need is more with United. My primary is actually Anthem. I mean, how will we, I just think that folks saw that and they're trying to figure out, I know it's going to come back to care coordinator will help that. I'm just hoping that that is in fact true, because the way that the letter read, as I understood it, these 3 MCEs were going to offer different kinds of coverage. And, you know, as you stated earlier, Cora, each situation is unique and we're dealing with very complex individuals. So I think that it's hard to, if I was a recipient, if I'm a member, looking at that and just feeling like, I don't even know where to start to make sure. And wondering if they can trust.
Yeah.
The care.
Well, and if I can
coordinator.
tell, real quickly touch on we have our enrollment broker, or Maximus, I don't want to say our enrollment broker. They are also, we set up a member support service call center that's just specific for pathways. So if they have questions that maybe the MCEs aren't answering or maybe not getting back to them on, we have and it's, it goes live, the members, in June, it'll be live in June. So we have it like an outside entity outside of the MCEs, where members can also call for support. And then that comes to our team, Kim and I, and we then have we also have a customer support team where we are, if it is something pertaining to the MCE, we have very quick turnaround to outreach to the MCE to have them resolve these things. And then the member support team will be forwarding over issues as well that they can't maybe resolve in a 1-call resolution. So we do have an outside entity outside of the MCEs that members will have access to.
Will we be capturing the effectiveness and ability for this outside group to manage this? Because if their services are not being able to meet the demand, or maybe there are maybe more information is gathered, are we going to be requiring them to gather the information, the questions, their ability to manage the calls? Will we be able to get that? Will there be transparency in that data?
Mm-hmm.
Okay,
Yeah.
that would be good.
Yeah.
Those are all contractual requirements of that vendor to provide us with that level of detail around what are the common calls, which, along with everything else we monitor with any call center, speed to answer, number of abandoned calls, those types of things. So it's a great question.
Top reasons for calls.
Top reasons for calls,
Okay,
how
great.
calls are resolved. The other thing I just want to make clear also is that the plans are required to cover the same benefits that are in Medicaid fee-for-service today for this population. There are not just distinctions or differences between the 3 plans and what they must cover. Where there might be differences are the added supplemental benefits, which might be things like a gym membership or home meals, like a meal, HelloFresh meal service. Those are really where the differences lie. So as far as things like their healthcare services and the like. There aren't distinctions between the three services. So I'd love to see, Senator, maybe we can connect after about, you know, where you were seeing, because if that was confusing, I'd love to know that feedback.
Well, I appreciate you picking up the HelloFresh example, because there were different nuances in access to nutritious food in each of the plans.
Sure.
And maybe it didn't line up with another unique
Mhm.
service that another plan offered. And yet this member needs something that is offered on the three different plans. I know, because I've heard from constituents about this very thing.
Sure.
And I think
That is.
yeah, and I do think
concern.
that there's lots of confusion. So 80% of the population is Medicare, is covered under Medicare. And so none of those providers are changing for them because they fall inside that Medicare bucket.
This would not be that bucket.
Right, so anybody all of, when we talk about like being in provider networks, majority of the providers are going to be paid under the primary payer of Medicare, and those networks are already established. They're probably already receiving services from those providers today. Anything that has to do with Medicare is not rolling into Pathways. Pathways is a managed Medicaid plan, so that's where the confusion, and I think that that's part of the confusion with the community as well. So it's trying to figure out this fine line between the benefits, and what Pathways was really kind of set up to do was coordinate as much as possible with those Medicare benefits so that there isn't duplication of services, so that when there needs to be a cost share between, Medicare claim being paid, that Medicaid is stepping in and paying that correctly and so forth. So as far as providers go, now the ancillary vision, hearing, some of those things are not going to fall into Medicare, but the
Food
primary
access.
providers.
And the food, access to meals or.
Yeah,
Or some.
so some of that, so that they will have access to those supplemental benefits, no matter if they have Medicare, Medicaid, or just Medicaid. Because the MCEs are providing that more as like promotional, like, it's kind of like your Medicaid, when you enroll in a Medicare Advantage plan, you kind of get all these extras to come to our plan. And that's what the MCEs, when you see those extra benefits, that's what they're really doing. They're offering these supplemental benefits to entice folks to join Anthem, or to enroll with Anthem, or to enroll with United.
So the prepared meals.
That's a supplemental, right?
That is supplemental.
Mhm.
In what was mailed, the only prepared meals was identified as post discharge from the
Yes.
hospital.
Mhm.
And I have constituents who need prepared meals and are receiving them under their, current Medicaid.
And that would be through their waiver, their Medicaid waiver.
Right.
Sorry.
And it wasn't identified in any of the three. So
Yeah.
can you speak to that?
Well, so I think I want to keep moving first of all,
Okay.
because just in the interest of time, and I know that there's plenty of questions around service coordination and the like. So I guess I would just say, Senator Yoder, also that the Maximus, our enrollment broker, is really skilled at being able to help constituents think through each of these different things, including the supplemental benefits or enhanced benefits that each of the three MCEs are offering in the Pathways program, and are really, we've written call scripts and are monitoring calls and helping make sure that we're counseling people so that they're aware of their options and they can make their informed choice. So that's probably the best place for if a constituent has a question about that. The home delivered meals, of course, are a waiver service, but then there may also be enhanced benefits that a plan is offering, like Holly said, just as sort of an add-on to their specific plans, like a gym membership or, those types of things. So those are kind of two separate things.
Yeah, and I'll connect with you when we're done, because I think that there's some things that you're saying that we probably need to update, because we call that the plan comparison guide, what you're
Okay,
referring
yes.
to. And I think that historically that's been used for HIP, Hoosier Healthwise and Hoosier Care Connect. But this group is going to be different because they also will have the waiver benefit under it, as well as Medicare benefits. So we probably do need to make some adjustments to the wording that's in there. So I'll connect with you after the meeting, and yeah, we can get some more information.
Perfect. Thank you so much for bringing that up. At this point, I'm going to turn it over to our Director of Clinical Operations, Giovanni, who's going to walk us through complex care transitions as well as service coordination under Pathways. Thank you.
So, okay, so there's a lot of complexities in pathways, and you mentioned one of them. One of it is, we know this is the most vulnerable population. Healthcare is complex, especially if they have Medicaid only, or they have Medicaid and Medicare, and then if they have Medicaid, Medicare, and waiver services. And if you're in an assisted living facility, in a long-term care facility, or receiving HCBS services, that is going to be a very difficult place to navigate for individual members. Part of the transition, a lot of these components that have been done, we understand there'll be patients who might be in a hospital on 7-1. And all of a sudden on discharge, they are now in a managed care entity and they were fee-for-service before. And their meals need to be delivered at home. Their AAA may not be participating into the Pathways program, and they may have a change in their care team, but not in their providers and how the providers communicate. So a lot of the work that has gone around this has been really to address those issues. So for example, the first piece that's on this slide is the broker, the enrollment process. Maximus is an expert in understanding who's paying the bills first and who's paying the bills for what. If you're a Pathways eligible member, but Medicare is your primary payer, they're typically going to work with this particular member to identify what medications are you on. Because under your state plan, your medications might be covered. They're the same regardless of what managed care entity. Under your Medicare, that may change. So they align to your point about who is the best plan based on your medication needs. Who's paying for your per diem, for your Medicaid, your Medicare supplements, for example, which is typically going to be Medicaid. Then identifying the services, are they already in a nurse facility level of care? What are the components? So a lot of the enrollment process is to allow the member to select the managed care entity that is best for them, that is going to align. That is what Maximus does. They do that today with the Medicare enrollment process, because what managed care entities compete on in the Medicare world are the supplemental benefits that you mentioned. Humana offers, for example, $300 a quarter for you to buy things over the counter through a catalog. Another one may offer you a vision benefit. Another one may offer you an enhanced dental benefit. Other ones offer you 10 meals post-discharge through Mom's Meals from the hospital, but that's only post-discharge. So what Maximus is helping do is identify the member. If you're already receiving your meal services through the waiver, that is just a constant ongoing component, right? You already have your meal delivery set up as your service plan. So part of this enrollment process is understanding that. So that care coordination piece is really to support the member. And then we'll talk about the specifics. What does the state do and then provide managed care entities to prepare for this? Service coordination is to support the members' waivers needs, because we understand that a lot of those components are be doing. Assistance with navigating both Medicare and Medicaid benefits. A lot of that work is going to be done because it's very confusing. The other piece is there's a member support service vendor that you mentioned, Cora, already. That's in addition to the ombudsman. Next slide, please. So the care coordination structure. All members, and this is the contractual requirement under the Pathways, is all members must be offered both person-centered care coordination, reflect the needs of the individual member, not a cookie cutter individual. It really needs to be comprehensive. There's actually going to be an auditing process to make sure that these service plans are indeed person-centered. They also have to, the MCEs are required to provide 2 levels of care management. Your care management that may just be like, assistance with managing your chronic conditions. Make sure that you're going to your cardiologist because your high blood pressure, cardiac condition, or diabetes is out of control. And then there's complex. And a lot of our members are going to be complex. Patients with dementia, for example, are maybe categorized as complex patients. For members that are receiving already long-term services or any HCBS services, the MC must provide both service coordination and care coordination. That is part of their contract. Those components are required. Also, we're going to ensure that the acute care primary and HCBS needs are addressed and coordinated. So how will we do that? Next slide, please. So part of the service coordination process right now is really the assessment and rediscovery of the patients. What is going on with the patient's needs? We rely heavily on the AAAs to do that today. A lot of those service plans and all that, actually all of the service plans are already in our CAM system, which is our agencies have access to. The nursing facility levels of care identified there. The vendors, the providers that are rendering that care are all identified there. The hours that have been authorized and the services that have been authorized are all in our CAM system as well. So these service coordinators, one of the things that we've been focusing on right now, if we anticipate that a particular MC is going to have a change in service coordinators because that AAA is leaving, how do they identify the care plans? How are we transitioning those care plans and how they identify who they need to be connecting with? Because they're also going to need to be doing some restaffing and reallocation of resources. I think that was one of the questions, right? On 7/1, your service coordinator may change. What are we doing in anticipation to prepare the member for those changes? Next slide. So that's where the transition of care comes in. Fortunately, the state does have a lot of data. One of the most frustrating things for patients, and when you go to a doctor's appointment and 5 different people ask you the same different questions because I can't read your chart. And one of the things that we try to address through this is the MCs have received 6 months of claims data for our members so that they really have a profile of the not only the services that they're accessing, but also the providers that they're seeing, frequent hospitalizations, et cetera. Their diagnosis. Also, they can see if that's what we call a frequent flyer in the hospital world, that they're constantly being readmitted to the hospital. That might be an indication that their conditions are not being well managed. High dollars, any claim over $50,000, right? What is going on with this member? Because that might be a high-risk member. Existing service plans that are already in CAMS are being provided to the managed care entities. The nursing facility level of care assessments are being provided to them as well as the existing authorizations, both on the medical and non-medical side, the waiver services. You mentioned about the network adequacy. Let's say, for example, I have my hip surgery scheduled for 7/15. The managed care entity will not be actually reviewing that for medical necessity. They have to honor as part of transition that particular outpatient surgery procedure or inpatient surgery procedure as scheduled. The same thing with the other components, with the service plans for the waiver services. Those components, that was given to the managed care entity so that there's no disruption. Anything that has already been authorized prior to 7/1 has to be authorized by the managed care automatically without any medical review or any process review. Next slide, please. So the managed care entities have a stratification process where they actually take a lot of this data. There are certain state required diagnoses and conditions that would qualify for complex care management. For example, if you're in a special needs program, a DSNP program that they call it under Medicare with the Department of Aging, that would categorize you as complex. Also diagnosis of dementia. There are certain diagnoses as well. So they take all of this data to really stratify who are your complex patients that we need to identify. If those particular individuals are also probably going to have a change in the service coordination piece, there's a communication plan. I think, Kim, you're going to talk about those pieces as well, right? Because now from a managed care entity, I know what my service plans are. I know who the current AAA is. I know who the service coordinator is. I know there might be a change, but I know what this member is now going to need. I know the providers are involved in those components. So a lot of these components will be done. And this is for the first time for 7/1. Every month, new individuals will enroll into Pathways. So the MCs will continue to receive this data. So as new members are added to the plan, they can go through the stratification process as well. So that's an ongoing process that we'll be doing with the managed care entities. Now, there's going to be some oversight as well. Each of the managed care entities, we will be reviewing 30, at a minimum, 30 service plans on a monthly basis. MC1 will be on month 1, month 2, month 3. And that is really to ensure that the managed care entities are following all the rules. So there's going to be a strict oversight and auditing process as well as we go through this. But the complexity is huge. This is some of our most vulnerable population, and the handoffs is really going to be critical. And that's how we're starting to stratify and identify those. I did this very quickly, so I knew that there were some questions that I want to make sure that I left time.
Thanks, Gina.
Thanks.
Tim, are we passing it to you next for the
I
stakeholder?
think so there- I think so.
Well,
Do-
we actually only have a few slides left. Maybe we could just go through them quickly and then come back to any questions.
Please.
Thank you.
So we just want to kind of review some of the transition plan communication engagement where they're doing with the members and the providers. And so this slide is kind of the high level overview. We are currently communicating with all three MCEs to align those communication transition points. All three MCEs will be contacting the members, as we talked about earlier, And the members will be receiving that handbook and the welcome packet.
Can you speak directly into the microphone? It sounds great when you
Oh.
do.
In
So,
addition to
thank
that,
you.
sorry, everybody. In addition to that, all three MCs will be doing personalized phone calls to the members. In those personalized phone calls, they will be identifying the language preference just to ensure that they are being able to communicate correctly. Also, will be introducing their care teams. And then they will also be reviewing and discussing their outreach for their coordination. How can they get a hold of their care coordinator or their service coordinator? In that time, they will have already reviewed the service plan, and then we'll have that opportunity to discuss with the members some of their upcoming appointments, some of the medication, to ensure that there is not an interruption in any care going forward into the transition. At the same time they're doing this, they're also to ensure that continuity of care and those authorizations that will be transitioning over to the MCEs. They will be doing outreach to each of the providers to ensure that communicating that they will be getting those new authorizations starting July 1st. They'll also be discussing with the providers that coordination of who they can talk to regarding those care plans and to review the care plans to ensure, especially since some of the current service coordinators may not be those that are continuing. They will also be reaching out to all current service providers to have a discussion on the current care plan to make sure that we have no interruption and that is continued through the transition process. Next slide. We also want to kind of just highlight some of the engagement. I know communication is kind of a key component through this process. This is just a high level. We have had tons more engagements, but this is just some of the engagements since March. We did outreach to the community engagement. We went around the state at 18 different events all the way through March to make it an opportunity for all of those people who are consumers, members that would be transitioning into Pathways to have that one-on-one availability to talk to the three MCs as well as a provider from the OMPP teams. Were at all of those to offer those questions and answers engagement going through there. We also have a targeted work group provider work group that we meet with monthly, as well as a stakeholder group monthly that we discuss different topics and different components of the transition into Pathways and trying to update and educate on that. We've also gone out to the individual different associations and done stakeholder presentations to educate, figure out how they can help us and assist us in this transition. So as I said, we've been to different associations talking about the enrollment process and what their role in helping and assisting the transition into the Pathways program so that we understand the community was part of this transition and we wanted to include them and make sure they were aware of that. We also have reached out to the SHIP to make sure that we are connecting with other programs that maybe will align with or overlap so that education, and those are done on a regular basis. We do that monthly. In addition to that, the HCP, as Holly had mentioned before, had the roadshow. We have been doing a half-a-day presentation with all three MCs available during those presentations to discuss Pathways, how it works, and having that available. And all of them had booths at those to handle any provider questions on a one-to-one basis. Next slide. So we still have several things still coming up. This is just some of the engagements that we will be upcoming that we have going. We still have our stakeholder engagement that we'll be presenting in June still. We also do have provider education. This week, we talked about care plans and service plans and how that's going to be transitioned over. We'll be really honing into HCBS providers, especially with the waiver, talking about the authorizations and making sure that they're aware of how that transition is going to be. We have other presentations at IU Medical Health. As we see, we do the SHIP. We also meet with the AAAs monthly. So we just wanted to make you understand the quantity of outreach and exposure that we are attempting to have so that we can make sure we're communicating with both all the members as well as the providers. And then in addition to that, I like to highlight and have everybody go back. We have a very robust thank you for the comms team for this, for our Pathways website. Included in the Pathways website, we have breakdowns for everything from the specialized member caregiver as well as advocate. There are resources and pages and highlights and all of our communications as well as all these webinars we post on a regular basis there. We have FAQs, so we accept questions and we like to post all the general questions so that we can be proactive as much as possible to answer all of the stakeholders' concerns and questions in the the implementation. There you go.
Thanks, Kim. Okay, so we're happy to answer any questions sort of as a team around anything in the pathway space at this point. If not, I'm not gonna.
No, I've been holding my question.
I was-
So, out of respect for the presenters. So thank you to all the presenters. So in the interest of time, I'll try to be as brief as possible. Let's talk about the breakdown in negotiations with CCHI, the termination of negotiations with CCHI. So at this point, how many AAAs or case management companies have entered into a contract with an MCE? How many contracts have been signed at this point?
Holly's going to count them up for us. I think it's roughly 10.
Yeah, so we have United has executed, has 3 contracts executed right now. And then they have 5 more. So that's with Socoa.
And maybe we should.
Yeah, would it be better if I provide this in writing to and break it down by MCE?
You're welcome to, and I would appreciate that. But since we're in the middle of a live meeting with lots of stakeholders watching, I'd appreciate it. I don't want to put you on the spot, but anything you can provide specifically, I think would be appreciated. Because we are up against a very critical deadline. So certainly there's an opportunity for follow-up, but if you can characterize as specifically as possible where we stand.
Yeah, so there's, the three executed contracts are Aging and Home Services, Socoa and Lifespan with United, and then they have 2 ICMs that are not AAAs that they're in negotiations with right now. And then they have 3 other AAAs that they're speaking to.
You're talking about United.
Yeah.
Yeah, and ICMs are case management companies.
Yes, correct.
Okay.
I'm sorry, I should have used
No, just
acronym. So United by far has worked their behinds off to really get working on these contracts. Anthem is in the final steps of executing contracts with I think area 8, and then I believe that there's a AAA in the southern part of the state that they're talking to right now. So they have sent us an update that they are wrapping those contracts up, that those should be executed very soon.
Anthem. Okay.
Yep. And then Humana feels very confident that they're going to have a contract with one of the AAAs, and they're talking to probably the same AAAs that like United's already working with. So,
a handful of AAAs versus 15 AAAs, big difference.
and the AAAs, there's lots of AAAs that have said we sent out an email asking, if you're willing to contract with the MCEs, and more than half said no. And so even with that, the MC still did outreach to discuss contracting. And these are the 5, the 3 that United, and then the 6 are really the only ones that have expressed interest to continue with discussions.
Okay. So one case management company is trying to negotiate with 2 of the MCs, or no, I'm sorry. You said United was trying to negotiate with 2 of the case management companies. Yeah.
Those same 2 are also talking to Humana and Anthem as well.
Okay. I have an Anthem specific concern. I have heard that Anthem is requiring an NDA as part of both the negotiation process and ultimately any contract that is negotiated. Have you heard that?
Well, it's part of, I think it's part of their master services agreement.
Yeah.
Because they're going to be using Anthem's proprietary IT platforms.
Yeah. Well.
Yeah.
I assume the other two MCEs have proprietary platforms as well.
And that would, I believe they are, pretty much all of their MCAs or MSAs say the same thing. I actually had them all send them to me last week so I could review them.
The only one I've heard that is requiring an NDA is Anthem. And I just want to go on record saying I don't think that should be allowed. So I don't know what authority you feel you have that the office has to intervene. But it flies in the face of transparency, including a lot of legislative discussions around healthcare costs in recent years. It is simply unacceptable. If an NDA is allowed, it will leave any AAA that agrees to an NDA isolated and helpless, unable to talk with peers or stakeholders about their experience or problems they may be having, or just the NDA is a terrible, terrible idea. And I wanted to bring that to your all's attention during this public meeting and put that on record. I don't think that should be on the table under any circumstances. If there are concerns about a proprietary system, then address those concerns narrowly. Require the AAA or the case management company to respect the proprietary nature of the system, but a broad NDA only benefits Anthem at the expense of not only the AAA but the consumers the AAA is serving and the state. So, transparency should be a top priority, and that flies in the face of transparency. I'm concerned about the readiness because I guess I don't know how we can say we're ready if we're still in chaos around service coordination. And so I guess a corollary to that is there have you established a readiness threshold for service coordination? For example, in order to attain readiness, will the MCEs have to document by some date certain that they have secured sufficient service coordinators for a successful rollout? And based on what I'm seeing and hearing, and based on what you just reported, with the small number of participating AAAs and case management companies, I don't see how we can possibly have adequate service coordination in place for a July 1 rollout.
Thanks for that question, Representative Clear. We have been monitoring multiple times a week, really, the staffing levels for each of the MCs. So although the contractual negotiations are still ongoing, as Holly mentioned in some pieces of the puzzle, we've made it very clear from the moment that CCHI opted not to participate as a network, that two things to the MCEs. One, that they were to make a good faith effort to contract individually with as many AAAs or independent care management companies that had interest in participating in pathways. As Holly mentioned, some AAAs or ICMs were not interested in doing so. Some wanted to become service providers and because of conflict of interest are unable from a federal standpoint to do both service coordination and be providers. Some wanted to focus their sort of book of business, I guess, for lack of a better term, in service coordination on some of our other waiver activities and the like. But the MCs continue to pursue, the contracting for those that are interested. Regardless of any of that activity, though, we have been very direct with the MCEs that on July 1st, they have a contractual obligation to ensure that caseload ratios are met for service coordination. And that is, of course, a blend of their own internal staffing and the AAA ICM subcontractor relationship. So we are monitoring very, very closely their staffing levels, their hiring levels for service coordinators, the model that they are employing. Some of them have opted to do a service care coordinator blended role, which is also assisting that. They're able to then recruit for that sort of dual role to bring that on. And so we're continuing to monitor it between Holly and Kim from the readiness perspective. Gio and his team are meeting twice a week with the MCEs on a transition basis to cover some of those things that he talked about in terms of making sure that they have a plan for how they're using the claims data that we have provided to them to ensure that they're isolating those individuals who are currently receiving service coordination and will continue to do so, specifically those who now will experience a change in their case manager, now called service coordinator. We also are in the process of developing some really specific public facing communication. I mentioned the A&D waiver communications, and of course, these individuals are on the A&D waiver today. They will be on Pathways waiver July 1st. And so as part of that communication strategy, we're also pulling together information for members on what they should expect if they're going to experience a service coordinator change, what the expectations of the service coordinator are, who to call if they're not happy with that service coordination, and the like. If the team wants to add anything, they're welcome to do so.
But we're not just going to take their word for it, right? I mean, when they're not going to,
They have reports. Gio mentioned sort of the auditing monitoring that is in place.
yeah.
And they're required to present to us very robust plans that we sit there, ask detailed questions about.
Which I appreciate, but it sounds like based on your description, there's already some fudging going on if they're now blending roles. You know, if service coordination and care coordination are being merged out of maybe expediency to meet staffing levels.
So that was their model to begin with, is when they divided out like the amount of outside service coordinators they were gonna have to hire with the AAAs. Their inside model was that their care coordinator and service coordinator was gonna be the same person, which does require them to be a clinically licensed position. And so what they've done now in the meantime, though, is that they've just been hiring service coordinators while in parallel with the contracting, and through attrition will be eventually then those service coordinators either will be moving on or whatnot, but they'll be moving people as they get those contracts over to the AAAs and so forth.
I know time is short. I want to move back to the waiver slots, if I may. So I think Senator Yoder raised this earlier. So I don't have the numbers in front of me, but you were saying, Ms. Steinmetz, that it was just north of 50,000. I think, if my memory is correct, I think we have 50,600. Yeah.
It's more than 50,500.
Yeah. Exactly. I think it's 50,600, but anyway, and we have 55,000, or we will have 55,000 combined pathways and health and wellness waiver slots, right? So it's not 55,000 pathway slots. It's 55,000 total between pathways and health and wellness. And you're apportioning those based on the current population. So we're going to have a net increase of, if our math is right, of about 4,400 waiver slots. But I believe the waiting list is already over 5,000. But we know that some of the folks on the waiting list won't ultimately qualify for a slot. So we're somewhere, you know, we're already someplace, maybe somewhere close to bumping up against the number of additional waiver slots, especially depending on how they're apportioned between the two waiver programs. So I asked this question the other day in the choice board meeting. Leslie Huckberry was there, and I asked, are we going to increase the number of slots. And of course, she said that was going to be a budget determination. So can you speak to that? Because it sounds like we may start out of the gate with few, if any, available slots, and we may end up with folks on a wait list again right out of the gate.
Yes, good question. There's one other factor that is really a part of the work that we're doing too, as Senator Fedora and I were discussing, sort of putting individuals into sub pieces of the waiting list from a categorization standpoint. And that is that we will also have additional slots open up because a waiver slot can only be used once a year. So if an individual passes away or moves out of state or no longer meets eligibility, those slots also will become available. So there is an amount that is more than the 4,400 that will open up on July 1 because of the new availability of those slots. So that's sort of that's one aspect of the data gathering that we're doing right now, is to isolate the number of those newly opened but not net increase slots. So that's where is a waiting list in state fiscal year 25 possible? And do I agree with Leslie that that will be a budgetary issue that we will need to present data and have discussions about? Yes.
Okay. I appreciate that. Yeah, I've never understood the slots being locked down for the remainder of the fiscal year if someone passes away or moves out of state. That's never made sense to me, but that's not something we apparently have any control over. I believe that's a CMS rule, right? Earlier, I forget who said it in their presentation, but they said that if I wrote it down correctly, 85% of Indiana Medicaid members are in a managed care program. Was that anticipating the MLTSS transition?
That's correct.
Okay, that's what I thought. So
Yeah, thank you for that clarification. I think it's roughly 83% or so today.
yeah, so I ran the numbers because I've been sitting over here doing math, and based on our population of 6.8 million and the slide that talked about almost 2 million people being on Medicaid, just to state this point, as of the April 2024 number in the slide, more than 29% of Hoosiers are in a Medicaid program, right at 30%, and about 25% of Hoosiers are in or will be in a managed Medicaid program, beginning July 1. So I just, lots of additional conversations that need to occur, but I appreciate all of the information that was presented today and the answers to all of the questions that have been asked. Thank you.
Senator Fedora?
Thank you. Appreciate it. I have, my first question ties back to the question about the wait list. Aside from CMS regulating when people can drop or add, and aside from any budget discussions, I don't understand the logic of someone medically qualifies to receive services. And we as a state determined that respectfully, we don't care about your, and I'm harsh in my words here, not directed at FSSA, but I'm talking about the policy. We are respectfully, regardless of your healthcare condition, it's a budget question and you have to wait. So I have to wait maybe 12 months, 8 months, 9 months, even though I need these services, just because the state did not fund these positions or these slots. Help me understand that logic. Is that a General Assembly logic, meaning that just it's purely a budget discussion that because the General Assembly didn't fund enough number of slots, people have to wait potentially up to 12 months, despite the fact that they need services because of that budget issue? Is that the main reason why we have a discussion about wait lists?
I'm not sure that I would characterize it quite that way, Senator Fedora. And one thing that I do want to make clear, which I know you know, is that the waiver does not is separate from an individual state plan services. So they, of course, are receiving Medicaid services. It mostly comes down to the setting in which they are receiving those services when we're talking about the waiver. And of course, the state is still very much dedicated to the goals of ensuring that more individuals can receive services in a home and community-based setting, if appropriate for their care and what they choose to do. And so that's a fundamental design of the Pathways program. So we are optimistic that if we can employ some of these other sustainability strategies as it relates to the waiver, we will be in a much better position that we can remove wait lists in the future and ensure that we have access to these services. Unfortunately, this is just an area where wait lists are common across the United States. 34 states at least have an HCBS 1915C, which is the type of waiver that this is, wait list in place today. So this is sort of one of the mechanisms that many states are unfortunately having to deploy at the moment as they try to right size their Medicaid programs and ensure that it is supporting as many individuals as appropriate and they can from an access standpoint while ensuring it maintains overall sustainability.
And I sincerely appreciate your answer. I don't mind challenging the status quo, and respectfully, if 48 or 49 other states have done it in a certain way, you know, I appreciated that FSSA was only one of 2 states that applied for more flexibility waivers. So it doesn't really incentivize me that other states are doing it in a certain way. But as a legislator, I try to walk in the shoes of a family that is struggling, that needs these services, and they are in a wait list. To them, it's perplexing that it's a budget issue. It's perplexing that it's a wait list. It's difficult for me as a legislator to go to my community and say, you know what, sorry, you're on a wait list for 8 months, but that further helps them believe that government has so many red tapes, not enough, you know, they're not managing their funds appropriately and so on. So it's very, very frustrating, extremely frustrating. Again, I'm not blaming FSSA for a wait list, but what I'm sharing with you is we, as state employees and as legislators, we are viewed by the public as we have the power to make changes. And the wait list is problematic. Even the term wait list for people who need services is problematic to communicate and explain to the public. So I appreciate your earlier comment today. I would like to receive information when appropriate before July 1st, if appropriate, to how many people are on the wait list versus how many open slots we will have, because I'll be more than happy to champion this cause with colleagues who are in the General Assembly during a budget session and say, FSSA is trying their best to help these constituents and these patients, but you guys in the General Assembly need to help us with the financial piece. So I really would appreciate that data piece. The second and the final question that I have, which we did not cover today, relates really to the structured family care, caregiving. And I just have a couple of questions. I went to the website of one of the healing hands, and I was specifically looking at the prior authorization hour specific piece where they said you don't need prior authorization hours to qualify. But somebody, I guess, from FSSA did communicate that the prior authorization hours are still required for anyone on the waiver or for that they have to secure those first. So can you help me, if anyone on your team, help me understand whether the PA hours are required or not required for structured family caregiving?
So it depends on the needs of a child, right? So, or the individuals receiving the services. For example, if someone's on a ventilator with a trach and G-tube feedings, et cetera, those are typically be considered skilled nursing services. A lot of the trach care, et cetera. Now, so a lot of those components need to be done through skill in the state plan amendment. There are certain things that only certain professionals can perform. Now, there are some, in some instances, that can be delegated and taught to a parent or to a caregiver, for example. So typically, when those services are required, they do have to go through state plan amendment. So by regulations first, the waivers are only supposed to provide services that are not part of the state plan amendment. So in the circumstances that something does require state plan amendment benefit, they have to go through that process first. And that's where we look at it is, and that's we have to say, in those particular areas, does that need to be provided through home health?
I appreciate it. It might be helpful maybe to expand that explanation when you communicate with the care coordinators or providers, because I think people are looking at their websites and what they're reading. At least I went to one of the websites and I saw it said that basically you might not need the PA hours. Your explanation is a little bit more expansive. And I think there needs to be probably a little bit more alignment of communication between FSS and these folks. The second and final question, for kids who are 80 or over 18 years old wanting to Or are they staying on the attendant care or are they moving or what is the status for those?
So the transition is based upon who is providing the care. So if an individual is a legally responsible individual, which is defined as a spouse or the parent of a minor, that is necessitating the transition from attendant care to structured family caregiving. So I think in your example, you said an adult
18 or
child,
older.
an 18+ year old.
Yeah.
Those individuals are not within the mandatory transition to structured family caregiving.
So they can
They're-
continue on the attendant care, not the structured family caregiving, correct?
Yes, and now we're testing my memory a little bit. This is on the website, so but I believe that a legal guardian of an adult child is restricted to 40 hours of attendant care, but still can still receive the service of attendant care.
And
There's a
if
number
they're-
of FAQs on that.
So if they're on the attendant care and they are over 18, should they expect any changes to what they are currently receiving after July 1st?
Not unless their spouse is the one providing that service.
Okay. If they are over 18 and they have a spouse, then potentially,
A spouse is defined as a legally responsible individual, and so those must move to structured family caregiving.
and if,
But if it's a non-spouse providing
Yeah.
it, then no, they're not moving to structured family caregiving.
and if they stay on the attendant care, there will be no changes. Assuming that there's no spouse legally responsible for them, there will be no changes to the service that they're receiving today, correct?
That well, I will say that the service plan serves as the authorization for those services. So as long as they still have a level of need that supports that,
Correct.
then yes.
There will not be changes as long as they have that level of need, correct?
Yes, correct.
Okay. Any updates? My follow-up question on the TBI waiver.
I'm sorry, refresh my memory.
So on the TBI waiver, I think there were, yeah.
Yes.
There are some issues that I've heard from some constituents about there are not approved providers yet that are able to provide some of these services.
To provide structured family caregiving.
Yeah,
I'm happy to connect with them because we have had over 200 providers be added through an expedited process to become structured family caregiving providers. So if we need to provide that information to someone so that they can get in the process and quickly become eligible for structured family caregiving provider status, we are happy to do
I
that.
think that would be helpful.
Sure,
And because again, I think we're running against the July 1st deadline, correct?
correct.
So having that list of providers available and communicate to the public might be helpful.
And Michelle, I'm sorry to put you on the spot, but we have the list of providers available on the website. Is that correct?
Yes, there's two lists of providers available on the website,
Yeah,
a
appreciate it.
statewide list and then a county by county list.
Appreciate it. Thank you.
I know we're almost at 3:30. And so Senator Yoder, did you have a question? Oh, okay. Oh, I'm sorry. Thank you, Gio. Representative Campbell, I'm sorry. I didn't see your hand up on this chat.
Thank you. So far this is about as clear as mud, so I'm trying to keep up here. So just going back and you have to probably remember the conversation. There was talk about coverage for things that have already been approved in the past would still continue to be provided for with that prior authorization. It sounds like when people are making a decision on which coverage they may be facing situations where some of their care won't be covered in the same way or not covered at all in the future. And I guess my assumption is if this is Medicaid, there's doesn't seem to be a continuity between the coverage. Is that fair to assume?
I think Gio's going to help answer this question. I think what you're referring to is very specific to the Pathways program, and we have a plan for how that's going to be handled.
Correct. So if the services are medical services, let's say, for example, your surgeries, your therapies, et cetera, and you're transitioning to Pathways on the managed care entity, the managed care entity has to honor those authorizations and provide those without any prior authorizations on their end. So they have to honor that from a continuity of care perspective. On the waiver services, if you already have an established care plan and services have been authorized, they have to honor those services as well, whether it's HCBS or MLTSS. So those components have to be there. Under the Medicaid state plan, if you're only Medicaid primary, all of the managed care entities must provide the same services. Now, they may provide some additional supplemental benefits. That's where the variation is, but for your core medical benefits, they are identical from one plan to the other. So that allows for the individuals to really have a fair transition of care. The challenges might be when it's Medicare, right? Even with Medicare, they're still going to have a transition of care and a continuity of care because Medicare does have those rules as well. That's where they may have different network or they may have different providers. But for the most part, everything will be identical as the authorizations transfer over. The managed care entities must honor those for 90 days at a minimum.
So there just may be a difference between this new managed care versus your standard Medicaid through the state.
Correct.
And we're giving people a choice to go off their standard Indiana Medicaid to this other choice.
Well, it's not really a choice. Once an individual that has Medicaid becomes eligible for Medicare, Medicare becomes their primary insurance. And then we typically become their insurance of last resort, typically end up paying for their premiums or their low income subsidies. But Medicare does become the primary insurance for those pieces.
Okay, so the people that are the 65 and older that are going on Medicare are not going to have any choice but to go onto this Medicaid Advantage plan, the Pathways plan.
So no, that gets complicated because for them to receive their Medicaid care coordination, they would have to enroll with one of the 3 MCEs. But they may choose to stay Medicare fee for service. They may choose any Medicare plan that is available in the market in Indiana. But in order for them to get the care coordination for Medicare and Medicaid, they would have to choose one of the 3 MCEs. But Medicare still does give the individual that choice.
And I would just add that on our Pathways website, we have some flow charts that break this down sort of in a simplified fashion to help understand that dual eligible enrollment piece about what if I have Medicare fee for service today and now I'm eligible for Medicaid and I'm going to be in the Pathways. And we're happy to send the link directly to you, Representative Campbell. That might be a good starting place for seeing the breakdown.
Okay, that would be really useful. My other question is, so, and this is probably just kind of ignorance on my point. Why are we changing over to this Pathways? What have we changed it from? Is this the Medicaid waiver is now going to be Pathways?
So this is broader than the waiver. About a little less than a third of the individuals who are on the Pathways program will be waiver members. So this is larger than that. There's a lot of information out there about sort of the program design and the philosophy behind it. But essentially the transition to managed care, and Gio, if you have any comments you want to add, really allows an opportunity. These things like care coordination that we're talking about and supports for members, quite frankly, are just things that in a Medicaid fee-for-service program directly from the state, very challenging for the state to have the resources to effectively carry out that meaningful care management. And so it will allow an opportunity for us to have this managed care partner assisting us in this work. As we said, 82 to 83% of our Medicaid population are already in managed care today. So this is a delivery system format that we're very familiar with in the state of Indiana. HIP, Hoosier HealthWise, Hoosier Care Connect, those are all Medicaid managed care programs that exist today.
Okay. And then I wanted to go back to the Anthem NDA. And will that prevent them from contributing to the claims data that we're collecting?
No, there's nothing in that space. They're required. That is Medicaid data. That is our data on the claims side. They're participating in the claims testing processes that we discussed, and all other claims activity is not impacted there. So thank you for that question.
Okay.
Senator,
just to follow up. So what are they saying that they will not disclose?
And Representative Campbell, I'll be honest with you, I haven't seen this, and this is sort of the first that I'm learning of this. So we're going to take that back and do some more investigation and talk with our Anthem colleagues specifically to get a better understanding of that. I think it sounds like it's probably some boilerplate language that exists in their master services agreement, but certainly understand Representative Clear's comments on that. And we will do our due diligence to dig in and see why that exists.
Okay, thank you so much.
Thank you. Senator Yoder?
Thank you. One question that I had was just to make sure that individuals who are eligible for significant like mobility chairs, significant equipment upgrades in that 5 years, I think there is a 5-year limit. Their limit was right around the time right now. And they were concerned that there was going to be a delay because they have been waiting to be able to get that upgrade. And there's not going to be any delay with their MCE, whoever they are assigned to or who they choose to sign up with. They can, there's not going to be an extended amount of time. The state will honor that upgrade immediately without any type of delay.
Yes, no changes to.
No changes.
Authorization.
Great. Thank you.
Yeah, thank you. Okay, we are quite a bit over, and I'm sorry, I had a lot of staff who had to leave for other meetings. So unless there is anything else, I think at this point, we can adjourn. If there are topics for our next meeting, which I believe is August 21st, obviously we'll give an update on how the pathways implementation is underway, as well as a number of these other waiver transition topics at that time. So thank you very much.
Thank you.